How's it going, guys? We have a medium difficulty question for pharmacology, rheumatology. 56-year-old woman has gout. We're handing you the diagnosis. We're obviously showing you the needle-shaped, negatively birefringent crystals, which you do on arthrocentesis. And we're telling you that she's had many episodes in the past. We're not trying to make this a differential diagnosis. Sometimes students might think a presentation like this is septic arthritis, but then you say, well, she's had a few episodes, right? Septic arthritis is not episodic. You don't have to have fever. You don't have to have increased serum uric acid with gout. That's a common misconception. Okay, so uric acid levels can be normal, but we're obviously handing you the diagnosis here. She's on hydrochlorothiazide, which can actually cause gout. Okay, so it leads to increased uric acid reabsorption, hypercalcemia, hyperuricemia, as well as hypokalemia, hyperglycemia. Those are side effects of hydrochlorothiazide. Okay, as well as offline NBME20, galacturia as well, weirdly, can be seen with hydrochlorothiazide. Proton pump inhibitor. Okay, so for peptic ulcer. So this is what's going to go down. Okay, we want to know for the acute presentation here, how do we treat gout? But we're asking you, the drug we use is most similar mechanistically to which the following. So normally USMLE wants indomethacin, which is an NSAID, and the answer would be naproxen, which in this case is the wrong fucking answer. Okay, and the reason it's wrong is because the patient has GI disturbance, gastritis, ulcers, history of GI bleeding. NSAIDs are contraindicated in acute gout. Okay, that's basic and high yield. Renal insufficiency as well. So rather than giving you esomeprazole for peptic ulcer, we could have said she has creatinine of 2.1, normal range 0.7, 1.2. Could have snuck that in there, made it easier, said she has a history of renal transplant. But you avoid NSAID, you avoid indomethacin for treating acute gout when you have renal insufficiency or you have history of GI disturbance, or obviously things like allergy to NSAID, where you get aspirin-induced asthma or NSAID-induced asthma, SAMP triad. So naproxen's fucking wrong, cyclooxygenase inhibition. The correct answer is going to be mebendazole, which is an anti-helminthic agent that inhibits microtubules, because the alternative to giving indomethacin is colchicine. So you'd say, we don't want to give her indomethacin, we would give her colchicine. What's the MOA of colchicine? Microtubule inhibitor, and then we look for one of those drugs. Could have been vincristine, vinblastine, mebendazole, albendazole for helminths, griseofulvin, antifungal medication. Paclitaxel, docetaxel are hyperstabilizers, prevent microtubule disassembly. All the other ones are preventing the assembly of microtubules, including mebendazole here. So colchicine is what we give this patient acutely. Fludrocortisone, it's a corticosteroid with strong mineralocorticoid effect that we give classically in Addison disease, patients who have a deficiency of not just cortisol, but also aldosterone. This is wrong because corticosteroids are not considered first line for gout. The literature is a bit annoying on it, because if you look up how to treat acute gout, they'll say NSAID, colchicine, steroids, but across USMLE, steroids are always wrong. Okay, and then other sources will say steroids are actually second line, which they are. So steroids are wrong in USMLE for acute gout. You go NSAID first. If you can't give the NSAID for whatever reason, or it's not listed, then they want colchicine. And then between flares of gout to decrease recurrence, i.e. we're treating chronic gout, then we give xanthine oxidase inhibitors like allopurinol, febuxostat. They're preferred over uricosurics like probenecid, because probenecid can cause uric acid stones. The thing you got to know about probenecid for USMLE is that it's one of its old school uses is it can help maintain serum beta lactam levels by inhibiting OAT, organic anion transporter, in the PCT and thin descending limb of Henle. Okay, so it decreases uric acid reabsorption and it decreases beta lactam secretion into the tubules for excretion. Let's just knock out the others. Cimetidine's fucking wrong, so that's an H2 blocker. So you could use this generally for GERD sometimes, or even thrown in with H. pylori regimens. It causes gynecomastia. USMLE wants you to know that H2 blockers are generally not preferred because they're competitive and reversible. They're not as efficacious as the irreversible non-competitive proton pump inhibitors when you're forced to choose between the two. Okay, so when we're, let's say, treating GERD, we do a 2-week trial of PPIs. It's diagnostic and therapeutic over the H2 blocker. But if it's not listed, you go with the H2 blocker. That happens once on a 2 CK level MDMA on one of the surgery forms where PPI is not listed. The answer is H2 blocker. But as I said, you just got to know setmelanotide causes gynecomastia for USMLE H2 blocker. Dicloxacilin's fucking wrong because we're not dealing with septic arthritis here. But diclox, this isn't doxycycline, dicloxacillin in the methicillin class beta-lactams, these treat staph aureus in addition to group A strep, strep pyogenes. They're heavily steric, so they're beta-lactamase resistant. Wrong fucking answer. You know the deal. I'm 2 minute more content on subscription. Appreciate your time. That's it.